as well as some time at the end to get into breakout groups to do some networking and ask additional questions of our CF Center staff. I will start by just showing you a few slides to get us oriented. Sorry about that. So this is the schedule for today. Just a little bit of an update about the CF Center and talking a little bit about COVID. Then Andy Littman is going to talk to you about becoming a CF warrior and his warrior project that he has created and really done a remarkable advocacy for the CF community. Patrick Flume, the Center Director at the Medical University of South Carolina, will give us a research update. And then we'll have a question and answer panel with the CF Center staff, followed by some breakouts arranged by age so that people can talk about issues that may be relevant for you or your family members or people that you know with cystic fibrosis. There is a Q&A in which you can ask questions throughout the presentation. There's also a chat functionality where you can comment or ask other questions among other people within the entire audience. Please make sure you check panelists and audience in the box so that everyone can see the chat messages. I want to thank our sponsors, the Herbert Behrman Foundation, as well as the CF Foundation. A special thanks to Rick Donnell and Simone Jowett, who have really helped us technically with getting this virtual session up and running. There's a couple of new faces in the CF Center I want to introduce. Megan Drews is our new physical therapist in the Pediatric Center. And Andrea Cunningham has taken over as the CF Registry Coordinator in the Adult Clinic. Kathy Danling, who's been the Registry Coordinator for many years, retired this year. It has been really a remarkable year. I'm going to focus just on three things. The fact that Trikafta was approved for people 12 years and up with at least one F508del mutation, what's going on at the moment with COVID-19, and sort of the revolution in care delivery that's gone on related to that in the CF Center. Trikafta was approved last October, and I want to step back a minute and make sure people are aware of what this means as far as modulators for CF. As I think many people know, CF is a chloride transport channel where you have ineffective chloride. I'm sorry, I just want to get a laser pointer here. So this is CFTR setting the cell surface. Chloride goes in and out of cells. CFTR is made from DNA, which turns into RNA, which makes a protein and gets through the cell. There are lots of ways where this can go wrong. And there are many different types of mutations. So for some people with class 1 mutations, they don't make any protein. For class 2 mutations, which is F508del or delta F508, it doesn't get to the cell surface. And other mutations, it gets to the cell surface, but CFTR doesn't work the way it should. Modulators are the class of drugs which are pills which work for these mutations, people that make CFTR, but it either doesn't get to the cell surface or doesn't work when it gets there. So when you look at the population of people that are eligible for modulators, it has grown over the past 5 years. So this is 2015 to 2019. The various colors are different types of modulators. The blue is the group that's not eligible for a modulator. This blue group is getting smaller and smaller as we go along, but we know that there are always going to be some people that are not eligible for modulator therapy because they don't make CFTR. And that's what Patrick Flume is going to mention and talk about in his research talk. Where do we go from here? Trikafta, though, has made a remarkable improvement in lung function in our patients. This is just the first 41 patients shown from the CF pediatric clinic, where the lung function when we started these people were 79% are predicted when you're looking at the FEV1, and improved to 92% after just their first clinic visit, so within 3 months of starting. We have over probably 200 people in the clinic that are now eligible or on these drugs, and this is something that we think is going to make a marked difference in improvement in health. One more illustration of this is data from the CF registry. This red line is the number of people that have a pulmonary exacerbation each month in 2019 before Trikafta was approved. The blue line is the pediatric patients and the exacerbations that they're having. Trikafta is approved here, and you can see there was a marked diminution in the frequency of people getting sick of those people that are on Trikafta. The pediatric population doesn't change very much because they're not eligible for the drug yet. We hope that there'll be availability of this drug for kids 6 to 11 sometime next year, probably in the spring or more likely the summer of 2021. You know, that's one remarkable improvement that we've had. But as you all know, we're dealing with a pandemic. As I often say, it's challenging times, you've heard people say. Just a few facts about COVID, so we're all kind of on the same page. It has lots of different names. SARS-CoV-2 is the actual name of the coronavirus, which causes the disease called COVID-19. It's an infection that's spread primarily by respiratory droplets. It typically, these droplets spread between 3 to 6 feet, but there's evidence now that infection can be spread by aerosols, which is called airborne spread, which means that they can spread in farther distances and stay in the air for a longer period of time, although this is not the major way this infection is spread. COVID infection does affect many organs beyond just the respiratory system. The only way we know really to prevent COVID is to prevent COVID. There is no cure. Wearing masks, staying at least 6 feet apart and distancing, washing hands, and really paying attention to whether you have symptoms or not. So if you think that you're symptomatic, to not go out in public, not be exposing other people, and talking to your physician about potentially getting tested for COVID to see whether or not that would be appropriate. You can always talk to the CF Center. In Maryland, as in most parts of the United States, the rate of COVID is increasing. This is data from the Johns Hopkins coronavirus dashboard, which can be found at coronavirus.jhu.edu. It's interpreted by the New York Times, but that's where the original data comes from. In the red, you can see the daily new cases, which really peaked in May and June, had another surge kind of in August, and now is rising again. The good news associated with this, although many people died early in the pandemic, fewer people are dying at the moment, even though there's an increase in cases. This relates to a couple of different things. One, that people are younger that are getting the disease right now. And also we've learned how to treat it better so that the patients have additional therapies that weren't available early on. This shows the number of specimens that are being collected. So there is more testing being done. And many people will tell you that more testing is one reason that we have more cases, but that's not the entire explanation. And that's shown here by the number of hospitalizations. The testing is relatively flat at a little over 1,000 per day, but we're still seeing a rise in hospitalizations, even though the testing is about the same, meaning that there are more people that are actually getting the disease. COVID tends to affect adults more than children, although children certainly can get sick. This is the age distribution from 0 to 9 years, 10 to 19 through adulthood. You can see the majority of the cases have been in the adult population. Although the older you are, the more complications and problems that you'll have. So what do we know? There'll be more infections this winter. This is something we're starting to see now as there's more spread as people come indoors. There's been a lot of discussion about children and whether or not they can get COVID. They certainly can. They tend to be less sick than adults, but certainly can transmit the disease to adults. We have some therapies that are available, but they're not curative. Remdesivir is available for mild to severe disease or mild to moderate disease. Dexamethasone for more severe disease. Convalescent plasma, which is antibodies from people that have already had COVID, may be effective in people with mild to moderate disease. Blood thinners seem to be effective for people in the hospital. There are a lot of additional medications being studied, and there are vaccine trials that are obviously going on now, and we hope to have results later on this year. So I often get asked what's going on with COVID and cystic fibrosis. At this point, there have been very few people that have been infected with COVID in the United States. This is data from the CF Foundation to the CF Registry. The adults are on the left, the kids are on the right. You can see the number of adults infected with CF reported to the registry in blue, and the percentage of those that are admitted to the hospital down here in orange. It's about 15 to 20% of the patients are admitted to the hospital with COVID. You can see early in the pandemic, though, when we did less testing, the rate of admission was much higher. So we don't exactly know how people with cystic fibrosis fare with COVID compared to the general population, but we know that they're likely to be at much more risk. Children, as I said, have fewer infections and a lower hospitalization rate as well. So what don't we know? We don't really know the true risk to people with cystic fibrosis. We don't know why some people have mild disease and others have prolonged symptoms. We don't know how long antibodies will last after you get infected and if they're going to be protected. And we don't know how well a vaccine is going to work when it's available. One of the interesting things that's occurred is that with COVID, there's actually been a decrease in exacerbations in the CF population. So this is the graph I showed you before, looking at the effect of Trikafta. If you superimpose this on the onset of COVID, you can see there's a continued decrease in exacerbations, which may be related to the effect of Trikafta, but it may also be related to the quarantine and social distancing and infection control that people with CF are so good at. You can see also that there's a decrease in the pediatric population. So this decrease from about 20% of what typically goes on in people with cystic fibrosis and kids with cystic fibrosis suggests that the infection control measures that we're doing have been very effective. Maybe I'll stop here for a minute and ask Noah Lechen or Christian Merlot, my adult colleagues, if they have any other thoughts about COVID and what's happening now in the hospital. As I said, this is mainly a disease that affects adults, and so Christian and Noah have been much more involved in taking care of those patients.
Thanks, Peter. Can you hear me okay?
Yes, we can.
Thanks. So for those who I haven't met, I'm the director of the adult CF program, but in addition to being a pulmonologist, I'm also a critical care physician. And in the spring and summer, was called upon to take care of a number of COVID patients who were hospitalized. And I think it's important for all of us to look back at March and April, which now seems a long time ago, but 7-8 months ago, when when COVID and the pandemic was brand new to us. There was a lot of confusion, a lot of things that we didn't know. As I think Peter mentioned, there's still lots of things that we don't know about COVID, but we've certainly learned a lot. But back in March and April, May, there were a very high number of patients who were hospitalized and a very high number of patients who unfortunately died. And just to put some concrete numbers around it, at Johns Hopkins, at one point, we had converted six intensive care units to just taking care of COVID patients. And at one point in the spring, we had roughly 120 patients with COVID in the hospital just at Johns Hopkins. And we really didn't know what therapy might be effective. We didn't have antivirals like remdesivir that have been shown to be effective. And so we were trying all sorts of different treatments. So if you remember back to the thought that hydroxychloroquine and azithromycin might work, there were also a lot of different medications that affect the immune system that people thought might work. And so patients were getting all sorts of different therapies, which have since been shown to be ineffective. But eventually, rates in Maryland and across the US did improve. And as Peter showed with those curves, by the end of June, beginning of July, things were looking pretty good. And then in August, rates went back up. And then they went down in the early fall, and they're now going up quite a bit. And just over the last couple days, we've seen rates that are higher or as high as they've been at any point in Maryland. And the positivity rate, which if you remember back to the time when Governor Hogan was doing a lot of press conferences and making policies, the positivity rate was something that has influenced a lot of the decision making, and the thought being that once the percent of positive tests is below 5%, it means the rates in the community are pretty low and we can relax some of the restrictions. And just over the last few days, it's now gone back up over 5% for the first time in quite a while. And I know Baltimore City has started to re-implement some of the restrictions on indoor gathering and mask wearing. And I'm really concerned that as November progresses and we get into the winter, we're going to see a pretty dramatic rise in COVID cases and hospitalizations. And so I think it's just really important to keep in mind that while our treatments have gotten better, while testing has become more available, there's still a lot that we don't know. We still don't have cures or a vaccine. And so I think it's really important that people continue to be very cautious and minimize their risks. I'll turn it over to Dr. Merlo to comment further and say, and perhaps mention lung transplant patients. Oh, you're muted.
It won't be a Zoom conference if somebody doesn't have that, right? Thank you, Dr. Mogazel. Thank you, Dr. Lexon. For those that don't know me, I'm Christian Merlo. I am the Associate Program Director for the Adult Program here. I've been at Johns Hopkins for over 20 years and have been taking care of patients with CF as well as patients who require lung transplants, who have advanced lung disease and ultimately require lung transplant. For people with CF who started on Trikafta, we actually saw a very sharp decline in the need for lung transplant in late 2019, early 2020. And so we initially had a pause and we thought, wow, this is great for those who are eligible and started on Trikafta. And then COVID hit and we had a pause for all transplants, not just for people with CF, but for all the others who had advanced lung disease. And we really got nervous because, as Dr. Lexon said, we had pretty much converted the hospital to a COVID hospital, and surgeries didn't happen for a while. A lot of things didn't happen for a while because we really didn't know what was going on. But eventually we learned about new therapies. We learned about different strategies to help people survive with COVID. And so eventually we started up with transplants again. And now we're running full steam for those who have advanced lung disease, not just people with CF, but all others with advanced lung disease. And transplants have happened. They've been safe, and people have done very well afterwards, which is really encouraging because we were terrified in the beginning, and I think we've figured it out, at least at our hospital and our system. The two other things I wanted to mention are hospitalizations for people with CF on the adult side have really declined, and we haven't actually seen many patients in in real life. Most of our visits have been telemedicine visits. And that's very similar on the transplant side. I've probably seen about 10 or 15 patients who have had lung transplants in person because we've been able to help monitor them remotely. And at least back in the spring, when we really didn't know what was going on in the hospital, we wanted to keep people away so that coming in, because we were afraid that if you came in, you'd get sick by coming into the system. Now we have much more rigorous infection control policies set up so that in the event someone gets sick, we have it set up to come into the hospital safely, and we also have it set up to come into the outpatient center on the adult side safely. So we feel very comfortable about that. And then as far as COVID in the transplant population, we've had maybe 2 or 3 patients who have had lung transplants develop COVID. All of them did well. And the 3 that I can recall did come into the hospital, but they did okay. And we were able to treat them and get them out of the hospital, and they have recovered. So again, highlighting all the struggles that we went through to try to learn how to best take care of you and your family members.
Well, thank you both for your perspective on this. I think that's very, very helpful. Let me just show a few more slides. There is a question here. I don't know, Noah, if you wanted, or Christian, if you wanted to answer this question, but I'm very concerned about COVID and coming into clinic, but I'm very eager to get on Trikafta. What do you recommend?
Yeah, so I saw that question. I'm glad you paused to address it. So as Christian said, early on, we were really discouraging patients from coming to the hospital, and I think patients were rightly apprehensive about coming to the hospital or to the clinic. But I do think we're at a point now where it's very safe and people shouldn't be avoiding care. With that said, we're going to talk about the adult clinic and our telehealth efforts. And so there's absolutely nothing that should prevent people from having telehealth visits. And so for something as important as starting Trikafta, I think beginning with a telehealth visit could be a very good way to address that. So please do not avoid your receiving health care because of concerns about COVID. There's one way or another we can address your needs.
No, I think that's a very good point. We really don't want people to put off contacting us and getting their routine health care because they're scared of COVID. We work very hard for inpatient care, but we also have virtual care set up as well. And I'm going to just show you a couple of slides to orient people to that as well. Sorry about that. It's always the way when you think you've got the whole thing organized. As Christian said, if Zoom always went perfectly, then, or if it always went perfectly, it wouldn't really be a Zoom meeting. So what do we need to think about in the future? Most schools in the area are virtual. Many are going back to in-person or a hybrid plan sometime this fall, winter, spring. So the things to think about with that are, is it the patient, their siblings, or actually a parent with cystic fibrosis that may be concerned about their health? Returning to work, the same questions. It could be the adult with CF, other adults in the household living with a person with CF or a child with cystic fibrosis. There's always some risk to being in groups. Everyone needs to consider their own situation, their own health, but also what the situation that the child or adult going to work will be in. So what's the plan for distance? What's the plan for mask? How are they going to approach people that might be sick? All those things factor into the decision making. It really is an individual decision for each person. There's a lot of discussion now about the holidays. We know that small gatherings are a frequent and increasing mode of transmission for COVID. And we really need to be cautious, I think, moving forward with being in gatherings for the holidays and at other times in enclosed spaces. It's much more difficult now as we get inside as opposed to doing things that were outside, like picnics and barbecues. And then what's the future of CF care? We talked a little bit about telemedicine, but also our in-person visits. You know, we're all getting tired too. You know, everybody's a little bit tired of being in quarantine, and everybody wants to be back to being perky and happy and getting our hair done. This is my poodle Darcy, who is very happy to be able to go to the groomer. So I wanted to just show you the short video that Megan put together, who's the social worker in the Dow Clinic, just to talk a little bit about coping in what are really can be challenging times.
Good morning to the Johns Hopkins Cystic Fibrosis community. My name is Megan Lagergren, and I'm the social worker with the Adult Clinic. I'm sorry I'm not able to be there with you live today, but I do want to take a few moments to talk about coping strategies during the pandemic and think about ways that you and your family can improve your ability to cope during this difficult time. Hopefully this idea of coping is not new to you and your family, since we've been living with this pandemic for the last 10 months. But I do want you to be able to walk away today with a few tips and tricks that could help your family thrive and do a little bit better during these coming colder months. I do want to acknowledge that individuals with CF and their families are not new to this idea of coping with difficult situations. I think your strength and experience in living with CF is definitely to your advantage. To keep it simple and easy to remember, I'm going to break things down into the 3 C's of coping today. That first C is going to be control. Reflecting on what you can and cannot control can be a powerful exercise and reminder of what we should be focusing on. If we are spending too much time worrying about the things that we cannot control, such as the pandemic, the results of an election, or the weather, we are at risk for increased anxiety and depressive symptoms. This is because we can feel overwhelmed or helpless when most of our energy is spent thinking and worrying about these things that we cannot change. A simple activity that you can do to illustrate this is to trace your hand on a piece of paper. Inside the hand will include things that you can control. Think things like how much time you spend watching the news or on social media, your attitude, how much effort you put into things, and how you take care of yourself. Outside of the hand, you will write things that are out of your control. Again, these are things that are like when the pandemic will end and when we will return to normal work and school schedules. Place this on your fridge or in a prominent spot in your home, and when you notice that you're becoming overly stressed, this can be a good reminder to focus on the things that are within that handprint. The next C that can help us improve our ability to cope is connection. All of you have already made the choice to connect with others by being here today, so you can give yourself a pat on the back. Even though connection looks very different these days, it is still as important as ever. Humans need to have that feeling of connection and closeness with others. Connections also help us learn and grow, and they give us the opportunity to focus on something other than ourselves. And that leads us to the third and final C, which is care. Take care of yourself first and foremost. It's okay to take a break from social media and current events and give yourself some extra love during these times of stress and change. Read or watch something that makes you laugh. Practice mindfulness by simply being in the moment. Take time to do things you enjoy, like listening to music, baking, painting, or exercise. Once you have a solid plan in place for yourself, then think about how you can take care of others. This is a simple and powerful way to lift your mood. Become a pen pal or send a card to someone in an assisted living facility. Call a friend on the phone, not text, or find a socially distanced volunteer opportunity in your community. And that are the 3 C's of coping. So think control, connection, and care. This is definitely an unprecedented time, and if you or someone you love needs more support, please make sure you reach out to your care team to be linked with additional resources. Take care and be well, and I hope you guys have had a great day.
I know that Megan would have preferred to be here and be able to answer questions, but I'm glad that she was able to make this video. I think that her advice is really spot on.
Good morning.
I want to switch gears a little bit to talk about our clinics. This is the pediatric clinic and visit volumes. You can see the dates down here at the bottom, starting in March. The green bars are in-person visits. And then going to where the pandemic really started to affect care starts in mid-March. You can see there's a dramatic drop in visits. These gray bars represent telemedicine visits, so virtual visits that are done with patients. We really switched completely to virtual visits in the pediatric clinic, and then made great efforts in May moving into June to reorganize the clinic, cut down on the number of patients that are being seen on any given day for all the patients so that we could streamline the move through the waiting room and into getting back into a room. And you can see now we're doing a combination of virtual and in-person visits. We anticipate in the future that this will change depending on what's going on in the community with COVID. The adult clinic had the similar drop in visits. They, however, have continued to, and have started doing telemedicine visits. They have continued to do the majority of their visits using telemedicine with just a scattered number of in-person visits. And I'll ask Noah to comment on that as we're moving forward in a minute. This is a picture of the pediatric clinic. This is I couldn't get the exact same shot, but you can see before here on the left with a lot of chairs and into the big part of the waiting room. And this is the clinic now, which has very few chairs. They are numbered so we can assign people to be in certain places within the clinic. Enhanced cleaning and flow through the clinic allows us to have fewer people in a safer space. And of course, we have new fashionable attire. These reusable gowns were actually made by the Ford Motor Company. They are the material that they make airbags out of. So this replaces some of our disposable yellow gowns. It's also safer for the providers because we can now run headlong into a wall and know we're safe because we're wearing an airbag. So maybe I'll stop there. Noah, give you a chance to introduce Christina and then maybe talk a little bit about what's going on with the adult clinic and sort of plans for the future.
Sure. Thanks, Peter. Wanted to take a minute to introduce the newest member of the adult CF team. Some of you have probably met Dr. Montemayor over the last year or two. Christina was one of our fellows. She was actually a medicine resident at Johns Hopkins and then a pulmonary and critical care fellow. And as a fellow, she became interested in cystic fibrosis and spent several years doing CF research and also seeing patients with CF, and has now joined the faculty. Her area of interest and research is pulmonary exacerbations and sex and gender differences in outcomes in CF, which she's been very successful with her research. And she's been seeing people in the clinic about once a week. So hopefully all of you will have a chance to meet Christina over the coming years.
And I will put in a plug here for our social media and, Meet the Team Tuesday, which is on Instagram. If you follow us on Instagram, you can meet the team and learn some facts about them beyond just what they do, at Johns Hopkins.
And so let me take a few minutes to talk about our clinic and what we've been doing. So as Dr. McGazel showed, in mid-March when COVID rates started to climb and all of the outpatient clinics were closed, we very quickly transitioned to telehealth visits. And I will say, I think we've done a great job in terms of continuing our multidisciplinary care. For the most part, I think the telehealth sessions work smoothly. All of the different disciplines, the nurses, the pharmacists, physical therapists, respiratory therapists, social work, all are on the telehealth visits and spend time with our patients, and that's been great. But I think the $1 million question has been, when are we going to resume in-person visits? And I think one thing that I want to get across is that we are happy to see people in person. And so if we think that there's a need to be seen in person, or if any individual with CF thinks they need to be seen in person or want to be seen in person, we will certainly make arrangements. But our default has been to continue with telehealth. And back in March, when we had our first telehealth visits, I think we drove our secretaries crazy, because they would say, okay, how should we schedule the follow-up visit? Should it be telehealth or in person? And we sort of said, it's March now. Things will probably be better in June, but just to be safe, let's just plan for telehealth, and we can always change it. And we sort of been operating on a week-to-week decision. Okay, is this going to be another telehealth week, or are we going back to in-person? And as COVID evolved and rates changed, we really haven't gotten to a point where we felt comfortable saying, okay, it's time to go back to just scheduling everybody in person. As rates started to look good in June, we started to think, hey, okay, maybe July will be the time. And then, as soon as we started to feel comfortable, rates started to climb again. And so we said, okay, let's continue what we're doing. And then again, by September, we started to say, things are looking pretty good. Maybe we can get back to in-person visits. And then sure enough, rates are climbing again. And so we are really trying to be cautious and not expose anybody to unnecessary risks. And again, I think telehealth and home spirometry are really coming along, and I think patients, for the most part, have been very happy with the telehealth visits. But again, if anybody wants to be seen in person, please call, let us know, and we will make arrangements. And we're continuing to just look at COVID rates week by week to try to come up with a time when we think it'll be safe to transition back to seeing the majority of people in person.
Thank you, Noah.
Dr. McGazel, there was a question in the chat, and it looks like Dr. Vanskoy responded, but maybe both Dr. Vanskoy and Dr. Lexon could respond to it. It's from Shannon Svikhart, who says, the move to virtual visits is awesome. We're grateful for that. If a patient must be admitted for IV treatments, is consideration being given to go home on IV more rapidly? It'd be great to decrease the length of stay, to reduce risks and improve everyone's ability to cope. I know that's a case-by-case situation, but man, it's a challenge in normal times. But during a pandemic, ...
That is a great question. I see Dr. Vanskoy is on. Maybe she could introduce herself and
Sure.
answer that.
Hi, I'm Lori Vanskoy. I'm one of the pediatric pulmonologists in the CF Center. And yes, this is always a challenging question. It's always hard to have our family members in the hospital, and it has indeed become even more challenging in COVID times with visitor restrictions that are even at Hopkins becoming a little tighter as we see our COVID numbers go up. So on the pediatric side, there are a few things that we have to have happen before we're able to consider sending you home. And first of all, I'll say, we will do our very best to get you out and home in as timely a fashion as possible. But we want to make sure that if you come into the hospital, we achieve our goals of getting you better, getting you back to baseline. And so one of the things that's always a challenge in pediatrics is we have to make sure you've got good IV access. So for those of you who don't have ports, we need to get your PICC lines placed and make sure that they're working and they're not having any problems before we can send you home. We also want to make sure, many of you are getting IV antibiotics that you haven't had before, and we want to make sure that those are being tolerated and that you're not having any side effects of those medications, and we need to get appropriate drug levels. And once we do those things, assuming that you don't require oxygen and you're tolerating your therapies well, we will try to get you out as quickly as possible. So I just want to reassure you that, one, we're doing everything we can to keep you safe while you're in the hospital, and two, that we're doing everything we possibly can to get you home as quickly as possible while ensuring that we're going to accomplish those goals of getting you back to baseline or better. And Noah, you want to comment on the adult side?
Yeah, I can really just echo what Lori said. As Dr. Merlot pointed out, we've had very, very few patients admitted to the hospital with pulmonary exacerbations since March. It's really just been a handful. It's always been our policy that for some patients who we know very well, who are on IV antibiotics fairly frequently, that sometimes they never come into the hospital at all. And so that's continued to be the case. So we will have a handful of patients who just manage the entire IV antibiotic treatment course as outpatients. But as an example, about 2 weeks ago, we had a patient in the hospital who was relatively new to us. We've only seen him once before. He had done IV antibiotics at home, but not since he was fairly young. But he was also apprehensive about being in the hospital for a prolonged time. And so he was in the hospital for about a week. We got antibiotic levels where we wanted. He had a PICC line put in. We were able to see that his lung function was improving. And he did go home to complete his IV antibiotic course at home sooner than we probably would have sent him home if it hadn't been during a COVID pandemic. So again, we really want to work with patients and their families to do something that works for them, but also makes sense medically.
No, that's very helpful. So I think we should move on. I want to just show one more thing before we're running just a little bit late. And that is about home spirometry. So we've talked about the use of telemedicine and home spirometry and alluded to home spirometry. We haven't talked about transition. Transition from the pediatric to the adult clinic has really been paused over the past 6 months. However, we are going to need to resume that moving forward because we are in a situation now where we're getting patients that are really going to age out of the pediatric clinic. So we're discussing and planning on doing a form of virtual transition visits for those young adults who are ready to transition. There'll be more to come on that in the next several months. Home spirometry is something that is being used by about 60% of the population. We're very grateful to the CF Foundation who have provided home spirometers to patients. We get about 10% of the population home spirometers each month. So about 60% have them now. We'll continue to provide those on pretty much on a monthly basis, so everyone in the clinic has one. So I think people have heard about home spirometry, but maybe not sure exactly what it is. So I just wanted to show you what home spirometry looks like and kind of what you should do when you have your home spirometer.
Hi, I'm Joey Miller, and I'm going to teach you how to do the home spirometry. And
Peter, we can't see the video.
Oh,
see
oh, I'm glad you said something. Oh. All right.
Hi, I'm Joey Miller, and I'm going to teach you how to do the home spirometry. And a special thanks to the CFF Foundation for making this possible for everybody at home. So first, wash your hands. Make sure it air dries and don't wipe it on your clothes or anything. Just make sure that you air dry it. And how to make it is, so for this orange piece, take this black part and put it in the hole in the orange, and then twist it so it's locked, and then touch the place where your mouth and lips don't go on, and then put that in the orange piece, and maybe push and twist, and just make sure that it's tight in. And then make sure that you have the nose clip. And once you get on the app, go to breathing tests, and then hit spirometry. And then here are the directions, and then hit continue once you know what to do. And then make sure that your phone is eye level, so you're not hunching down, because that makes the air come out not as well. And then oh, and yeah, also don't breathe close to this, because this is very sensitive and it'll take in soon. And then once you're done, so here's what you got. I got an 85%. And then you can either go to next test, like quit and save. Make sure you do it 3 times. And then I'm just gonna quit and save. And then it saves it to your saved, and it will send it to the CF Foundation at Johns Hopkins. So, and then how to take it apart is pull this out just by like right there, and then for this, what I like to do is just push it, and then put it in here, just drop it in the alcohol, and then close it, and then take an alcohol pad and wipe down this. And then why not just wipe down your phone, because that just cleans it and it's safe. And then make sure once you're done, or before you do it, that you switch your height and weight like every 3 months or every time it switches. And don't, make sure not to give up, and yeah.
So I want to thank Joey for making this video. As I said, we're working to get everyone home spirometers, thanks to the Cystic Fibrosis Foundation. I mentioned already our various social media pages. We have social media across 4 different platforms. Also on our website, hopkinscf.org, all the social media feeds to there. So if you'd like to just check our website out periodically, you can do that as well. The CF resources to think about and remember: Compass program that can help with financial issues, insurance issues, legal issues, just questions in general about access, and then Peer-to-Peer Connect, which is available for both adults and spouses and teens now. To remind everybody where we are, we're running a little bit late, but Andy Littman's about to